Welcome to the Deep Dive. You're here for a focused look at a really key topic in pediatric medicine, especially if you're prepping for the MSRA exams. Transposition of the great arteries, or TGA.
Yeah, TGA. We've basically boiled down a whole lot of notes to the absolute essentials.
Exactly. What it is, why it happens, the effects, what else it might look like, who gets it.
How it presents, diagnosis, treatment, and the long-term picture.
Our mission today is pretty simple. Give you a really clear, high-yield grip on TGA. Ready?
Absolutely. TGA can seem, well, complicated at first, but if we break it down step by step, the main ideas should click.
We want to give you those key points, the ones you need for learning and recall.
Precisely.
Okay, let's dive straight in them, the basics. In simple terms, what exactly is transposition of the great arteries?
Okay, so basically TGA is a heart defect you're born with. It's like a mix-up in the heart's main outflow pipes.
The big arteries.
Right. The pulmonary artery and the aorta, they're hooked up to the wrong pumping chambers, the ventricles.
So the aorta, which should get oxygen-rich blood from the left ventricle to the body.
It's actually connected to the right ventricle instead. And the pulmonary artery, which should take the oxygen-poor blood from the right ventricle to the lungs.
Comes off the left ventricle. Got it.
Yeah, it's a complete switch.
Wow. So that kind of reversal,
Yeah.
it must have some pretty immediate, pretty big effects for a newborn.
Oh, absolutely. This anatomical switch leads to a very specific and problematic blood flow pattern.
How so?
Well, the oxygen-poor blood coming back from the body goes into the right side of the heart, but instead of heading to the lungs.
It gets pumped straight back out to the body by that misplaced aorta.
Exactly. And at the same time, the oxygen-rich blood coming from the lungs enters the left side, only to get pumped straight back.
Oh, to the lungs again, via the pulmonary artery.
Right. You end up with two separate circuits, basically running in parallel. They don't connect properly.
So one circuit just keeps sending blue blood around the body, and the other keeps sending red blood back to the lungs.
That's a good way to put it. That analogy you mentioned, like two trains on different tracks that never meet.
Yeah, it really paints a picture.
It does. It clarifies that core problem.
Yeah.
These two loops mean the oxygen exchange, the vital bit between lungs and body, just isn't happening effectively.
Okay, the anatomy makes sense now. But why does this happen? What do we know about the causes, the risk factors?
Well, the exact cause for TGA, like with a lot of congenital heart defects, isn't fully known. We don't have all the answers.
But there are clues.
There are. We see patterns that suggest genetics play a part. For instance, sometimes TGA runs in families.
Okay.
And it's also worth noting TGA sometimes appears alongside other heart defects, and those can definitely influence things.
Right. And what about things during pregnancy?
Yeah.
Are there known maternal risk factors?
Yes, several have been flagged. Things like pre-existing diabetes in the mother,
Okay.
using certain medications during pregnancy, alcohol or drug use too,
Yes.
and infections are another one.
Infections.
Rubella, German measles specifically, has been linked to a higher risk.
And you mentioned genetics earlier. Are there specific syndromes linked to TGA?
Yes, it's seen more often with certain genetic syndromes. Down syndrome is probably the best-known association.
So it seems like it could be a mix of different factors. Is there a way to maybe remember these risk factors easily for exams?
Let's see. How about a mnemonic? Maybe DIABDG?
DIABDG. What's that stand for?
Drugs, infections, alcohol, babies of diabetic mothers, and genetics.
DIABDG. Okay, yeah, that could be useful. Drugs, infections, alcohol, babies of diabetic mothers, genetics. Nice one.
Hopefully it helps stick.
Right. So let's dig into the pathophysiology a bit more. How exactly do those two separate loops cause the problems we see?
It really all comes back to those distinct blood flows. You've got the pulmonary circuit, oxygenated blood goes lungs, left atrium, left ventricle, and then, whoops, back to the lungs via the pulmonary artery.
Right, stuck in a loop.
And then the systemic circuit. The oxygenated blood comes from the body, right atrium, right ventricle, and then gets pumped straight back to the body via the aorta.
Still deoxygenated.
Still deoxygenated. So the crucial problem is that the oxygen picked up in the lungs just isn't getting delivered out to the body's tissues where it's needed.
Which explains the cyanosis, that blue tint, right? Because the oxygen isn't reaching the skin, the organs.
Precisely. The body tissues are effectively starved of oxygen, and conversely, the lungs just keep getting blood that's already oxygenated, which doesn't help the body at all. It's inefficient.
So those parallel loops directly lead to inadequate oxygenation systemically.
That's the core physiological problem.
Okay. Now, if a newborn shows up with symptoms like cyanosis, TGA is high on the list, but what else could it be? What are the main differential diagnoses.
Yeah, that's crucial. You need to think about other congenital heart conditions that can present similarly, especially with that early cyanosis.
Like what?
Well, there's truncus arteriosus. That's where you have just one big vessel coming out of the heart instead of two separate ones. Then double outlet right ventricle, where both the aorta and pulmonary artery mainly come off the right ventricle. Also, Ebstein's anomaly, pulmonary atresia.
Tetralogy of Fallot?
Tetralogy of Fallot, definitely. Also, total anomalous pulmonary venous connection and tricuspid atresia.
Wow, quite a list. So the initial signs might overlap.
But the underlying heart structure, the anatomy, is different in each one, which is why getting the diagnosis right is so important.
Absolutely. So speaking of getting it right, how common is TGA? Let's look at the epidemiology.
Okay, the numbers. In the UK, it's estimated at about 1 in every 3,500 live births.
So not incredibly rare.
No. And it actually makes up a fair chunk of all congenital heart defects, maybe 5 to 7%.
Right.
And if you look specifically at newborns with cyanotic heart disease, the ones presenting blue TGA is the most common cause right at the start.
Really? The most common?
Yeah. It's about 3% of all congenital heart disease, but around 20% of the cyanotic cases in neonates. So the overall incidence works out to roughly 1 in 4,000 live births.
Interesting. Any difference between boys and girls?
Yes, definitely. It's more common in males, about a 3-to-1 ratio, male to female.
And you mentioned risk factors earlier. Do the epistats back those up?
They do. The data points again to things like maternal rubella, other viral illnesses during pregnancy, maternal alcoholism, mom's age being over 40, and maternal diabetes.
Okay.
One interesting point, though, TGA isn't usually linked strongly with other non-cardiac syndromes or malformations, which is different from some other heart defects.
Good to know. And understanding these numbers helps with what? Planning services.
Exactly. Resource allocation, planning care, guiding research, knowing the epidemiology is really fundamental for all that.
Makes sense. Okay, so we know roughly how common it is. Now let's get back to the baby. What are the classic signs? How does TGA usually show up?
The absolute classic sign, the one you usually see first, is cyanosis, that bluish color of the skin, lips, nail beds. And it typically shows up pretty soon after birth.
Right away.
Often, yeah. Then, as the baby tries to cope, you might see other things develop over time, like breathing really fast, getting sweaty, especially during feeding, and just generally poor feeding.
And what if there's another defect, like a hole between the ventricles? A VSD?
Ah, yes. If there's a large VSD present, these babies can develop signs of congestive heart failure more quickly. So very rapid breathing tachypnoea, a fast heart rate, tachycardia, and that poor feeding again.
Okay. And when a doctor examines the baby, what might they actually find?
Well, sometimes, interestingly, the baby might be quite blue, cyanosed, but not look particularly distressed breathing-wise.
Really?
Yeah. And listening to the heart, if the ventricular septum is intact, you might hear a second heart sound, S2, that's single and quite loud.
Single and loud S2.
Okay. If there is a VSD, then you'd likely hear a systolic murmur, that whoosh sound of blood crossing the defect.
Makes sense.
And if the TGA also involves pulmonary stenosis, a narrowing near the pulmonary valve, you might hear a specific type of murmur called an ejection systolic murmur.
And the timing of the cyanosis, when does it usually become obvious?
It often gets worse after the ductus arteriosus closes. That's the fetal blood vessel connecting the aorta and pulmonary artery.
The one that normally closes after birth.
Right. While it's open, it allows a bit of mixing between the two circuits, which can slightly help oxygenation. Once it closes, that mixing stops and the cyanosis often deepens.
And other clues?
Low oxygen saturation, obviously, picked up by pulse oximetry. That's a big one. And then there's the chest x-ray finding.
The egg on side.
The classic egg on side, or sometimes called egg on a string appearance. It's because the aorta and pulmonary artery lie parallel instead of crossing, which changes the silhouette of the heart and the great vessels. It's quite a memorable visual clue.
Definitely memorable. Okay, quick question then for everyone listening. Newborn, central cyanosis soon after birth. What's a key finding on listening to the heart that might suggest TGA if the ventricular septum is intact?
Based on what we said, that would be the single, loud second heart sound, the S2.
Spot on. Single, loud S2. Okay, so we suspect TGA based on these signs. How do we confirm it? What tests are involved?
Well, sometimes the process starts before birth with antenatal ultrasound. It can sometimes pick up TGA.
But not always.
No, the detection rate antenatally is still less than 50%, unfortunately. But when it is detected, it can help plan for delivery and immediate care.
Okay, so after birth,
Pulse oximetry, like we said, usually day one screening picks up low sats, then the chest x-ray looking for that egg on a string, or maybe signs of increased blood flow to the lungs if there's a VSD.
And ECG.
An ECG might look normal initially in a newborn, but later on, it can start showing signs of the right ventricle working harder, right ventricular hypertrophy, and maybe the right atrium too.
But the main diagnostic tool is
Echocardiography. No question. That's the cornerstone. An echo gives detailed pictures of the heart's structure and function.
so it shows the swapped arteries clearly.
Absolutely. It shows the aorta coming off the right ventricle, the pulmonary artery off the left. It assesses how well the heart's pumping, checks for VSDs, any other associated issues. It gives you the map you need for planning treatment.
And what about things like cardiac catheterization?
Usually not needed just for the diagnosis of TGA itself. It might come in later, maybe before surgery, specifically to get a really detailed look at the coronary arteries, how they branch off.
And cardiac MRI.
Not typically used for the initial diagnosis either. Echo is really the key player there.
So it progresses from screening like pulse ox to imaging like X-ray, then the definitive detail from the echo.
That's a good way to sequence it in your mind, yeah. Screening, basic imaging, detailed anatomy.
Okay, so we've got the diagnosis confirmed, TGA. What happens next? What's the management plan, both immediately and long-term?
Right. Immediate priority is managing the low oxygen. Minimize the time the baby is hypoxic.
How?
The crucial first step, as soon as you suspect TGA, is starting an infusion of prostaglandin E1.
Prostaglandin. Why?
It keeps the ductus arteriosus open. Remember that vessel connecting the aorta and pulmonary artery? Keeping it open allows some vital mixing of the oxygenated and deoxygenated blood between the two circuits.
Buys some time, improves oxygen levels a bit.
Exactly. It's a bridge to surgery. And at the same time, you need to arrange urgent transfer to a specialist pediatric cardiac center.
Got it. And the decidative fix.
That requires surgery. The main operation, the standard of care now, is the arterial switch operation, or ASO.
Arterial switch, what does that involve?
It's complex surgery, usually done in the first few days or weeks of life. Surgeons basically cut the aorta and pulmonary artery off their incorrect ventricles.
And switch them back to the correct one.
Precisely. They reattach the aorta to the left ventricle and the pulmonary artery to the right ventricle, but crucially, they also have to move the coronary arteries.
The heart's own blood supply.
Exactly. They need to be carefully detached from the old aortic root and reimplanted onto the new aorta, the one now coming off the left ventricle.
Wow. Sounds intricate.
It is. But the long-term results after a successful ASO are generally excellent now, with low mortality in centers that do a lot of them.
Are there other surgeries?
There's another one called the Rastelli procedure, but that's usually reserved for specific, more complex cases, maybe involving VSDs and pulmonary stenosis. The ASO is the main one for straightforward TGA.
Okay. And after the surgery, what's the follow-up?
Intensive care initially, of course, then long-term, lifelong follow-up in specialist congenital heart disease clinics is essential.
Lifelong.
Yes, even into adulthood, just to monitor for any potential late issues.
And you mentioned prostaglandin before surgery. Is there anything else done preoperatively?
Sometimes, yes. If the mixing isn't good enough even with prostaglandin, they might do a balloon atrial septostomy. It's a procedure done via catheter. A balloon is used to create or enlarge a hole between the top two chambers of the heart, the atria. This allows better mixing of blood at the atrial level.
Another way to improve oxygenation before the big switch.
Exactly. But it does have its own risks, so it's done when necessary. The overall goal of all this is clear, though. Restore normal blood flow.
It really sounds like the surgical advances have completely changed the game for these babies.
Yeah.
What's the typical outlook, the prognosis these days?
Oh, absolutely. The progress has been phenomenal. Both surgery and medical management have dramatically improved the prognosis.
And the key is that early surgery.
Timely arterial switch operation is the biggest factor, yes. Get that done successfully early on, and the outlook is generally very good.
So most kids can lead pretty normal lives.
The vast majority, yes. Most infants who have successful repair can expect to lead healthy, full lives.
But there can be long-term things to watch for.
Yes, that's why the lifelong follow-up is key. Potential issues down the line can include things like heart rhythm problems, arrhythmias, issues with the coronary arteries that were moved, and sometimes, eventually, development of heart failure, though often much later in life.
So regular checkups are vital.
Absolutely, proactive monitoring and management. But the survival stats are really encouraging now. After an ASO, you're looking at 90–95% survival at 15–20 years.
That is really positive. But let's talk a bit more about those potential complications. What specific things might crop up, either soon after surgery or years later?
Right. So early on, besides arrhythmias or maybe temporary heart failure, there are surgical site issues to watch for. Longer term, we mentioned arrhythmias and coronary artery problems. Pulmonary hypertension can sometimes develop.
And you mentioned neurodevelopmental issues.
Yes, unfortunately, there is a higher rate of neurodevelopmental delays seen in children who had TGA. Also, specific issues related to the aorta repair itself can occur.
Like what?
Things like narrowing of the new pulmonary artery, neopulmonary stenosis, or leakage of the new aortic valve, neo-aortic regurgitation. The root of the new aorta can sometimes dilate or stretch over time, too.
And the coronaries again.
Yes, obstruction or narrowing of those moved coronary arteries is a big concern, particularly in the first 3 months after the ASO. It's a major cause of problems, even death in that early period.
Leading to?
Reduced blood flow to the heart muscle, myocardial ischemia, or even heart attack, myocardial infarction. The risk is highest early on.
And sudden death. Is that a risk?
It's uncommon, thankfully, maybe 0.3 to 0.8% incidence, but it can happen, often related to those arrhythmias or ischemia. Usually occurs maybe 1 to 5 years after the switch.
And the neurodevelopmental side needs close watching too.
Definitely. Early and ongoing assessment is really recommended. We know that being born very prematurely or having high lactate levels before surgery, signs of significant stress and lack of oxygen are predictors of poor developmental outcomes.
It's lots to monitor.
Yeah, and even years later, echoes might show subtle changes, like the right ventricle changing shape slightly or its function decreasing a bit. It just reinforces why that regular expert follow-up is non-negotiable.
This has been incredibly thorough, a real deep dive into TGA. Just to recap the absolute key takeaways for exam revision. TGA means switched great arteries, leading to 2 separate circuits. Main sign is early cyanosis. Treatment is the arterial switch operation, ideally done early. Prognosis is much better now, but lifelong follow-up is crucial for potential complications.
That sums it up perfectly. It's a serious condition, yes, but the advances mean the outlook now is vastly improved.
Okay, and that leads us to our final thought for you, the listener. Thinking about those long-term risks, what do you see as the really critical areas for ongoing research and innovation, especially managing TGA survivors as they grow into adulthood? It's definitely a field that's still evolving.
Definitely food for thought. And just a reminder, if you are prepping for the MSRA or want more high-yield revision stuff, do check out passmsra.com.
And freemsra.com for free resources, too.
That's right.
Thanks so much for joining us for this detailed look at transposition of the great arteries. We really hope it's given you a clear, useful understanding. Until next time on The Deep Dive.